welcome to Toward a Quality of Life. Here on Thursday, May 9th, in the month of May, a rather cold, drizzly day in May outside here in the Boston area. And today we're going to talk broadly about the subject of depression, major depression, as it's technically called in psychiatry, and bipolar disorder. You've probably heard a lot about those terms in your comings and goings. And with me tonight is Dr. Andrew Nierenberg from Mass General Hospital. Thank you for being here.
Thanks for having me.
You're welcome. And Dr. Nierenberg is a graduate of Albert Einstein College in New York in 1980, where he received his medical degree in psychiatry. And since that time, he has now become the medical director of the bipolar program at Mass General, the associate director of the depression program at Mass General, and an associate professor of psychiatry at Harvard Medical School. He also has numerous articles, reviews, chapters in books to his credit at a relatively young age, as you can see. So he's quite dedicated and prolific, and I might add that since the year of 1994, he's been voted into the group of best doctors in America for treatment of patients by his peers, a voting that's done by other doctors as to whom should be chosen. So that's quite a good honorarium to have at your name. Okay, now. When you were just talking to me before the show started, you said to me that there were a lot of minimal understandings or not very good comprehensions on this whole subject by people in general outside the profession. What did you mean? You said sort of misperceptions even.
Well, a lot of people have mood disorders and don't realize it. And what happens is that they have a terrible stress usually, and then they find that they just don't enjoy life, they can't sleep, they don't want to eat anymore, and then they think it'll just go away, and sometimes it actually does. But a lot of times it doesn't, and it takes them a long time before they end up trying to get some help and actually get a diagnosis.
Is it hurtful to an individual to carry on without seeking help under those circumstances? Does it do any harm?
Well, the harm that it does is that it's very difficult for some of these people to function, and it's hard for them to function well if they're feeling down in the dumps and blue and they feel hopeless. If they're not sleeping, then they're tired during the day. It's hard for them to concentrate, to do their work, and what happens is that their productivity goes down, it affects their relationships. So the longer that goes on, the worse it can be for people.
In other words, they could dig themselves into a hole that they can't get, that would be harder to crawl out of, so to speak?
Well, the deeper the hole, the harder it is to crawl out of.
I see. Okay, now, does it become chemically harder to treat depressions that have lingered for a longer time?
Not necessarily, but, you know, some people think that it may just be chemical, or it may be a chemical imbalance is what you may hear, or maybe it's just psychological. But really, I think what we're learning is that it's almost always both. That usually what kicks off the first depression is a bad stress. Whether it's a loss of somebody you love, whether it's the breakup of a relationship, whether it's the loss of a job, a loss of money, anything that's important to somebody that they lose really turns out to be a terrible stress. And we now understand that stress itself affects the brain. And over time, there's an interplay between how somebody can cope with things, the stress, and how their brain reacts. So the longer it goes on, the worse it is both for somebody psychologically and for their neurons, for their brain too.
Mm-hmm. I myself am not an either-or person about therapies, so-called psychological or your inner being, whatever you want to call it, and your chemistry, because I look at chemistry as the correlate of whatever you are at a moment.
Right.
In other words, the brain in a particular state is you in a particular state.
Right.
So one is the substrate of the other. So I don't look at, like, I've seen in papers where studies of the chemistry of the brain during depression call it abnormal, but really it's sort of a normal situation of a particular psychological state or a behavioral state, if you will. It happens to be a state that you're in. So I look at it as a more unified thing.
Well, it very much is, and there are studies that show that people who are depressed have different areas of their brain with different activities as compared to people who are not. And they just published a very interesting study that showed that people who are depressed, when they're presented with negative or upsetting words, that their brain reacts to that and doesn't go back to normal for a longer time. So the areas of the brain that show that you're upset linger longer. They can't shake the feeling.
What about the stress of everyday life that's not traumatic, so to speak, like breakup of a relationship? What about having to get your work in by a deadline, or taking extremely crowded trains, or being, you know, on a schedule such that it's easy to be late all the time? What about just what we call routine stress?
It's bad for you. Basically, it's not good to be stressed. It's not good to be stressed all the time. It's bad for your body. Your body actually reacts to that, and so does your brain. And especially if it's really bad. For example, one of the worst stresses I think people can have is if their marriage is not working, or if their really close relationship is full of turmoil and fights and disagreements, and that they don't feel safe in those things. That's a horrible stress for people to have over a long period of time.
So would you advise that people not be in situations, broadly speaking, where it's perpetual conflict with no particular resolution seemingly feasible?
Yes, I think it's certainly not good for people to be in that situation.
To be living in that kind of thing. And we often do, because we have a need to be attached. We don't want to be lonely, so we go with something substandard just to not be lonely, right?
Right. Can't live with them, can't live without them. But if it's terribly stressful, it's not a good thing for you.
And are there any studies working on environmental factors that are contributing to depression that just are tantamount to the speed of life, you know, to...
It can be. For some people, they get very excited and they feel good about the speed of life, that it's going so fast and it's wonderful and they can cope with it. Other people, it's horribly stressful. And that's where there's great differences among people, so that for one person it's not stressful, and for another person it's terribly stressful. So it depends on who they are, it depends on how they cope with things, and also depends on their genes. So there are some people who can be extremely stressed, but they don't get depressed. There are other people, when they have the same stress, they get depressed.
But we also hear about burnout. Remember, we used to hear about burnout a lot, so that sometimes people could be doing fine for a long time and then all of a sudden run into a very rough period.
Oh, yeah. Yeah. Well, life tends to be very stressful for many people at many times, and there are many different flavors of it. You know, for some people, their work may lose its meaning, their relationships may lose their meaning, and that in and of itself is very stressful.
And I think, too, rather than just calling it constitution as to where you sit on the curve of how you react to stress, I think we could talk, too, more about the dynamics of the personality of how you react to stress. It's not just whether you're strong or weak, but a lot more to, like, how you interpret, like, what are the things that motivate you, what are the goals you have, what makes you feel good and what makes you feel bad, and who you are as a person.
And what happens sometimes is that people do a lot of self-talk, so that if they make a mistake, there are some people who will say, okay, I made a mistake, I'll learn from it, I'll do it better next time. There are other people, when they make a mistake, they start calling themselves names, they think they're terrible, then they think they can't do anything, and then it just sort of snowballs. Sometimes there are specific therapies that can help that if people do get depressed.
Yes, and that in and of itself seems to harken back to developmental situations where one person may theoretically have been told all the time, that's okay, try this one, you can do it, and the other person, look what you did.
Right, you're a dummy, you're dummy, you're an idiot, and you're yelling at them, not accepting them. And sometimes people have those tapes basically play
The learned
again.
features of the fact of us being learned creatures, creatures of habit, creatures that get indoctrinated in
Right.
effect just
Right.
by living with the physical universe and with the personal universe. So I would like to also take a look at the Diagnostic and Statistical Manual of Mental Disorders, which is put forth by psychiatry to describe these two major disorders that we're talking about. And mainly, we'll just look at depression for the moment. And let's take a look at some of these. Do you agree, first of all, with the criteria for major depressive episode as it's listed in the manual?
The manual is reasonable in terms of making the diagnosis in a very systematic way, so that if you or I are talking about somebody who has major depression, then we know we're talking pretty much about the same thing.
So you would go along with that. Would you add anything that might not be in here?
Well, these are sort of the basic aspects of it, and it doesn't capture the real flavor for how people suffer and how they have difficulty. But it's good enough, at least for communication.
So we say depressed mood most of the day, by subjective reports, sad, empty, or others see the person being tearful. Can a person be tearful and depressed and not know it, that others may see it, but the person may not know it?
Yeah, sometimes. Sometimes it comes on so gradually for people that they can't even see it. And for some people, it goes on for such a long time that they don't know what a normal mood is anymore.
Okay. All right, so a sad mood, that's true. That's true. That's a good point. You don't know what normal is. Been down so long, it looks like up to me.
Right.
As a matter of fact, when I was thinking about this program, not just today, but I'm not a happy person. I'm an unhappy person. I mean, I'm not a person that believes you can find happiness. I'm not stuck on that, finding happiness. It's not a goal of mine. But when I hear people, be happy, I'm not a happy person, but I'm not unhappy being unhappy. If that makes sense.
Right.
I could not say that I'm a happy person, but I'm not unhappy about it.
Well, it's very interesting because we all have a tendency to have a certain amount of our thoughts either be positive or negative. So we could tend to be optimistic, we could tend to be pessimistic, we could tend to really take things to heart all the time, or you could go, what the heck, things are okay. And we're all built a little differently, so that the amount of time that we spend thinking positively or thinking negatively is actually quite varied. And some people have a long-term propensity, a long-term tendency, a long-term habit of really seeing the glass half empty, really being pessimistic. And sometimes it's harder for those people to be happy.
Yeah, well, and what does the word happy mean, too? Happy, unhappy in as much as you're really feeling low and lousy, that kind of unhappy, or just like, hey, I'm not joyful. It's not, I'm not that kind of a thing where you're not depressed, but you're just like, it is what it is. It ain't all that. More like the Jerry Seinfeld show. It ain't all that. You know what I mean? Okay. And then a diminished interest in things. Could you say a little bit about that?
What happens when people get depressed is that they lose interest in the things that really just made their day, that would make their lives. They lose interest in their hobbies, in their sports. They even withdraw from their loved ones. So if you have somebody who just loves playing pool or loves playing golf or basketball or any sport that they enjoy or anything like that, they just don't want to do it anymore. It's as if they look at it too closely and poof, the meaning of it goes away. People
the relevancy.
The relevance. It's like people can be very passionate about following sports, professional sports, and all of a sudden the Celtics don't mean anything, or the Red Sox don't mean anything. They just withdraw. And the main point is that it's a change. And usually they don't really notice it, but their loved ones do.
What does it mean when it's said clinical depression versus depression?
Well, depression is an unfortunate word because we use it every day. It's not just a feeling state. It's not just a way you feel now because you lost your watch. I'm so depressed, I lost my watch. The clinical depression is trying to describe some of the things you're talking about, and that if you have at least 5 of these symptoms, then you have clinical depression.
Right. That we can say technically you meet our definition. Okay, and the diminished interest, anhedonia, hedonism, where life is a gas and everything's great and all things are pleasurable, to anhedonia, where no pleasure in anything.
And that's actually one of the most painful things for people when they say they just don't feel any pleasure at all. And that's all day long. Nothing gives them pleasure.
Yeah. Yeah. What does the person do who loses interest typically? Sit on a couch, go to bed, stare at the walls?
There are people who would tell me they'll sit in a dark room and stare at the wall and do nothing. Do absolutely nothing.
For hours
on end.
Until eventually they may not be able to go to work, and
right.
At that stage they're not doing anything.
Right.
Yeah, that's very serious depression. I would assume that some of the clients you see, and you see clients, and there are studies going on at Mass General that you're involved in, and we'll mention those a little bit later, but I would assume a lot of the people in those have decidedly met criteria for the clinical, quite clearly.
Well, we actually, we have people like that, and we even study milder forms of depression.
Milder forms of depression as well. Okay. That's pretty sad business. Significant weight loss when you're not really trying to lose weight.
These people, it's as if they lose all of the important biological things. So people lose any desire for food. They don't get hungry. They don't want to eat, and they start to waste away. It's really, people can lose a lot of weight, and it's not desirable when they do that. The other thing that happens is they lose their appetite for sex, so their sex drive can go out the window. They also can have tremendous trouble sleeping, and even to do that, they just can't do it.
Okay. And insomnia or hypersomnia.
These are the people who retreat to bed, sleep all day, can't get out of bed, so it can be either way, but it's clearly a change for the worse.
Psychomotor agitation.
These are the people who simply cannot sit still, can't feel comfortable sitting still anywhere. They'll get in a chair, get up, go over to another chair, they can't get settled, they get up again, they pace around, they sit on the bed. Those are the people who are agitated.
That's not quite anxiety, is it?
It could be mixed with it.
It could be mixed with it.
But it describes the physical restlessness that people can have.
It's kind of a ill-at-easiness, which is a bit different than a wretchedness, if you will, rather than an anxiety. Yeah. Or psychomotor retardation.
These are the people who, it's amazing when you talk to them, because you'll ask them a question, and you and I have a particular rhythm to our conversation. I say something, it's a slight pause, then you'll say something, or we might overlap a little bit, because that's what people do. And when people have psychomotor retardation, you ask them something like, how are you? And they'll just sit there. And 30 seconds or a minute later, much longer than you'd expect, they might say, oh, not so good. But they're not moving as fast. They're not thinking as fast. They feel like they're just trying to move through molasses.
And have there been brain changes that have been studied in relation to that?
Yeah, there have been brain changes related to all of these things.
I'm sure. This is where people can often get confused with having other kinds of problems, cognitive mainly, which means thinking problems, brain reasoning problems, and so on, can be confused. They could be deeply depressed and have this slowed processing, and people could consider them to have a cognitive problem instead of depression. Fatigue or loss of energy, no energy.
They just can't do anything. They feel either tired all the time, or if they do the slightest chore. I have somebody who would go out, might be able to go grocery shopping, comes back home, can't do anything else. That's all they could do all day long. And then they would either just sit and do nothing, or they go from one chair to another, to the bed and back. It can be quite mixed.
So then this depression really is sapping the body's resources.
Oh, yeah.
And steroids are being produced, probably, that are...
Yes, a lot of times these people have much too high levels of steroids in their body, natural steroids.
Which would be, after a while, really taking its toll.
Yeah, oh, yeah.
Okay. Feelings of worthlessness.
People always judge themselves. And some people feel an inherent sense that they're worth something. And most people do. Most people actually feel reasonably okay. It might change, it might wax and wane over time. But what happens when people are depressed is that they feel that they're worthless human beings, that they have no worth at all as a person, that even compared to other people, they're nothing. And they feel that they're nothing. It's also particularly painful. And again, it's usually a change.
A change, I see, where this starts in. And excessive or inappropriate guilt could be the other possibility.
Yeah, these people can feel guilty about things that they either shouldn't feel guilty about or they couldn't feel guilty about. So that they dwell on all the things that they've done wrong in their lives or what they did recently, blame themselves terribly, and some people feel like they even deserve to suffer.
Do you think then that people who are able to feel guilt and able to feel self-recrimination would have a better, unfortunate chance of becoming depressed in periods of trauma versus a kind of character that doesn't have that capacity?
No, but we've actually done studies that showed that out of a large population, the people who had low self-esteem to begin with were much more likely to eventually become depressed as compared to people who had good self-esteem.
Okay. And diminished ability to think or concentrate.
Yeah, we talked about that.
Yeah, that's terrible.
Yeah, these are also, the people can't read. You know, these people who would read all the time, they're people where their concentration is so impaired, they can't even follow a story on TV, they can't have a conversation. It's very painful for them.
That's very bad. And decisiveness, indecisiveness, that's a biggie. I think a lot of us have that trait, not to the extent maybe of clinical depression, but that's a very common human feature, indecisiveness.
Except if you exaggerate it.
Exactly.
Should you buy this bread or that bread, this brand or that brand? And you can't even make that simple decision.
Paralysis of
should
will.
I do this one or that one or this one or that one? And they can't decide the smallest things to do.
You know, as we talk about these things, for some reason I'm just thinking of how in the past religion would talk about this kind of thing, like self-doubt, torture, you know, worthlessness. It's funny, you know, that coming into into this century with secularization, etc., new ways of looking at maybe somewhat things that share some characteristics.
One does have to worry about somebody who completely wallows in guilt. And if they're spending all of their time wallowing in guilt, something is probably wrong.
Okay. And unfortunately, thoughts of death, this is the very difficult one, recurrent ideas of suicide. And
suicide is one of the great epidemics of our young people. And you may have seen in the news in the past year or so that a lot of college students are actually killing themselves. It's among the top causes of death of people between the ages of 15 and 30. That people feel that there's no hope. And if there's no hope that anything will ever get better, and if there's no hope that they'll feel better, and if they feel like this pain that they feel, the depression that they feel, is never going to go away, then one way for them to solve the problem is to kill themselves. Other people may feel so guilty and so badly about themselves that they feel like they deserve to die. And this, again, is a very painful state for people to be in. And usually they feel two ways about it. They want to die and they don't want to die. And a lot of times this is when people will seek help, when they're feeling that way.
Mm-hmm. Yeah, suicide is feeling suicidal is very painful from a behaviorist point of view, and people don't understand this. You can easily get to a point where nothing is reinforcing, so to speak.
Right.
You can really get there.
Well, just imagine if you can't feel pleasure, and you can't concentrate on anything, and you're not interested in anything, and you're blaming yourself for everything, and you feel like you're nothing. And it's a horrible state to be in all the time.
But how about the other fact, too? Wouldn't there be a zeitgeist to this, too, considering that more people are feeling this way, that bombers are willing to take their lives, and that, like you say, right in our country, or these Columbine and this person who's doing the pipe bombing and all this kind of thing, isn't it a sign of the times, too? Isn't there an interplay there?
Well, there can be. It's very hard to know. Certainly one of the things that's been debated is whether or not more and more people are getting depressed. One of the things that's been debated is, if that's true, why? And there are some theories that many of us have lost any sense of community, that we tend to live relatively isolated lives, and there's no buffer for stress. So at a time when people had close-knit neighborhoods, if something bad happened, a lot of people would come to help them. Now people live far away from their families, and a lot of people spend too much time watching TV and doing nothing else, and not having interactions with people. So without that buffer, without that help from other people, there's a question of whether or not more and more people are getting depressed.
Many has been the time when I've said on this show that happiness or well-being can only come by relating. If you're not truly relating, that's the only key. There's no pharmacological agent, there's no, and we're going to get into that. Nothing can substitute or make well. Existence is given meaning by meaningful relationship. And by that, I don't necessarily mean my true love, my significant other. I mean, you get a parking ticket. Oh, man, you've got somebody who knows you that you can tell. You go back to wherever and say, guess what? And you get to tell it, and somebody else knows about it. That's relating. That's relating. Rather than you get there, oh, this is appointments here, you've just got to handle that, it goes by the wayside, you carry it alone, and anyway, everybody else, they don't really know you, you're not going to get into that with them, and that's where we're losing a lot of traction, that kind of a thing.
We're social animals.
We're social animals.
That's what we are. We need each other.
That's the meaning right there. We're social. Even if we live alone, we do so in reference to the rest of society.
Right. Well, one thing I do want to mention is that suicide is a huge problem, and over the past 20 years it's becoming even more of a problem for the African American community, and it's an awful problem where a lot of people end up not getting help, and so it's hard for people to recognize that they have depression. It's hard for them to get access to care, and we're specifically trying to launch some programs at Mass General Hospital so that we can increase awareness in the African American community and that we could help people who really need that help. But the rates of suicide are going up.
Right. Well, I definitely feel it's the way we're living, and anytime you do turn on the television, the diet is totally desultory, totally derogatory. I have many channels, and I can't watch. It's click, click.
500 channels and nothing's on.
Everything is about doing harm, harmful world, lousy people, deceitful people, hypocritical people, everything. Comedy is a very, very small fraction.
Well, but it's also a little bit like alcohol, where alcohol is not necessarily bad, but if you have too much of it, then that's not good. And if people are spending 6, 8, 10 hours a day watching that stuff, that's a problem. Because it also means they're not relating to people.
But that's right. But let's look right now. If you were to keep up with events and they're on your shoulders because the news is making it such, look at the events that are on your shoulders, the pipe bomb or the anthrax, the 9/11, the Middle East, Saddam Hussein, the Afghanistan. Look what's on your shoulders.
Well, the rates of depression and things like that have gone up since 9/11.
Oh, and when people who are mentally unstable are watching these things,
right.
Oh, geez, it has a very big effect on them. Yeah. Okay, so now, one other aspect of depression, though there's so much more, well, a couple of other aspects. One is atypical depression. What does that mean?
There's a classic picture of depression of people having no pleasure whatsoever, of not being able to sleep, of not being able to eat. Atypical depression is that these people can actually feel a little bit better if something good happens, but it doesn't last that long. And these people also tend to overeat, so they'll eat a lot of sweets to comfort themselves, and they tend to oversleep. So it doesn't look like classic depression. It looks a little different, and that's why it's called atypical.
Okay, and what is melancholia?
Melancholia is people waking up much too early. So they might go to sleep okay, but then they'll wake up at 4 o'clock in the morning and they can't go back to sleep. They feel horribly guilty about things, feeling that they've just done terrible things. Very bad loss of interest. Those are the sorts of things that would make up melancholia.
And most likely agitated.
And many times agitated. Or slowed down.
Or
either one.
slowed down too. Okay. And I had one other feature of depression that slipped my mind that I wanted to ask you right then and there, but until I remembered that. What about psychotic aspects of depression? Are there psychotic aspects?
Yeah, sometimes people can lose touch with reality when they're depressed. And these are people who can either hear voices, or they might see things that aren't there, or more commonly, they have thoughts that can't be true. So they may feel that no matter what their doctors tell them, they have cancer, and the cancer is eating their brain. Or that they may be people who have certainly enough money to live on, not a problem, but they feel like they have absolutely nothing. They have no money whatsoever. There are other people who may feel that strangers want to hurt them when there's no evidence for that whatsoever. So they lose touch with reality.
And is that because they are so depressed, or is that just individual differences of how depression could manifest itself?
It's one of the ways that depression can manifest itself, but it's a particularly severe form of it.
Particularly severe form. Okay. And are there any people trying to speak out or bring greater attention to the idea that the way we're living, the inputs or the lack thereof, are contributing greatly to a lot of mental disorder, and that should be looked into, and that we should take a strong look at how we're organized as human beings?
Oh yeah, a lot of people are trying to look at that, both in terms of what's happening in our society and for individual people. Sometimes when psychotherapy really works for people, it helps them understand what they're doing and how they're living that's not helping.
Right. And they're still having to go back to a lot of those conditions that might have brought them to where they're at. Yeah. Okay, now in terms of medications and in terms of therapy, we won't get into the therapy too much, but at Mass General, I guess they're doing a lot of cognitive behavioral therapy with people who have this disorder, and that would be, as you mentioned before, working on the ways people think, the patterns they have, recognizing them, having alternative ways of looking at things.
Right, it's helping them think about how they're thinking. Because many people assume that the way they're thinking must be true. And if they're thinking negative ways all the time, that's the way they see it.
Especially if they're not talking to other people.
Right, that's right. Then there's no feedback at all.
Not just about being depressed, which mostly you probably wouldn't, even in a regular society, except to a real good confidant. But when you have a lot of relating, just in general, about nothing in particular, your cognitive field is kept more in order. It keeps your cards all in a deck, so to speak. You know.
Right. You're getting more feedback from
in
people.
General,
you're not just living in your own head.
You can't just go off into these tangents, which I also believe is responsible for some of these murderers doing, to the degree that they do, because deviancy can really proliferate when there's no checks and balances and nobody knows anybody. Okay, and the cognitive, the behavioral part of the therapy, are there any kind of...
Well, for example, if somebody feels that no matter what they do, they won't feel better, part of the behavioral part of it is saying, well, you may not think that you're going to enjoy going to the movies and seeing that movie that you wanted to see, but why don't you try it anyway, even though you think you won't enjoy it. Try it and see how you feel before and see how you feel after, and then report back. And so in starting to do those things that could possibly be pleasurable, people start to actually experience pleasure, and it starts to break through their depression.
Okay. But if they can't find someone to talk with and have companionship, they might have a difficult time all the
Right.
same.
So part of it is if somebody's having no companionship, what are the steps that you take to be able to start to have that and actually to build relationships with other people?
And you know, networking is not companionship either.
Right.
This whole thing we have, that's not companionship.
Right, but you know, it helps people to volunteer if they're not volunteering, or if they're working, to start asking coworkers, why don't you come out to lunch, and start to have a back and forth.
Right. But it's a far cry. I go back a little bit further than you. It's a far
Not
cry.
that much.
It's a far cry from when we really knew each other. There could be a book, When We Knew Each Other.
Right.
Okay. Now the medications. How do you go about thinking what to prescribe, or are there some people who are clinically depressed for whom you might not prescribe a medication?
Well, for many people, it turns out to be a negotiation, and that some people are willing to take medication, other people are not, and it's important that we inform them that they can have cognitive behavioral therapy, for example, as one particular treatment, or they can take medication, and in a sense negotiate what they'd rather do. There are many people who are helped tremendously by medication, and there are some people who are not.
Okay, now, how do you go about deciding? Well, why don't you first break down for us the basic categories of medication that you would consider for depression, and why, what the features are?
Well, the basic categories range from the Prozac-like drugs. So you may have heard of drugs that have been on the market now for quite a while and have been famous. So there are the Prozac-like drugs, and you may hear Prozac, Zoloft, Paxil, Celexa. These are the major what's called SSRIs, or selective serotonin reuptake inhibitors, that affect mostly serotonin. Then there are some other newer drugs like Effexor.
Before what does it do to serotonin, and what's the significance of serotonin?
Well, it looks like the regulation of serotonin is abnormal in people's brains. And it's a brain chemical. It's a brain chemical. One of the newer theories of how these actually work is it looks like it goes against the effects of stress. So people's brains react in a particular way to stress, and it looks like the antidepressants actually fix that. And they do it in very complex ways. But the SSRIs are just one class of medications that seem to do that.
Which allows for more serotonin to be available to the areas that it's needed.
Right.
Okay.
That's right.
All right, that's one.
Then there's something called Effexor, which affects both serotonin and norepinephrine. There's another one called Wellbutrin that affects norepinephrine. Some people also know it by the name of Zyban because it also helps with smoking. So it helps with depression, helps with smoking. There's another medication that's called Remeron that's completely different and works in some other ways, also affects serotonin and norepinephrine. And then there's a whole class of older drugs called the tricyclics, and people may have heard of Elevil. They may not, but that's an older one. And then there's some other ones that aren't used that often.
Okay, and how do you decide what to do?
Usually when I see a patient, when my colleagues see a patient, they'll go over all of the symptoms, make a diagnosis. Out of the symptoms that we talked about, if you have 5 of those symptoms, then you have clinical depression. And then may go over at least just a few medications and then go back and forth about which side effects may or may not happen. and then people really choose out of a small
You choose
menu.
by the side effects?
Usually, yeah.
Okay, what are the worst side effects to people?
Well, one of the side effects that people can get with the SSRIs, the Prozac-like drugs, is that they can get sexual side effects. Either they can lose their sexual functioning, or they can lose their libido, their appetite for it. But a lot of times it actually gets better because it's already bad when they're depressed. The other things that can happen is some of them are associated with long-term weight gain, which people don't like.
That's a very big problem.
They can have dry mouth, dizziness, constipation, things like that.
Yeah, very big problems. I see.
But you know, it's also important that most patients can actually tolerate the side effects, and they feel like it's well worth it. And many times the side effects, if they're bad, they can be managed with sometimes other medications.
And how long does it take for these medications to kick in?
It can take anywhere from 4 to 12 weeks to get the full effect of the medication. And what's very important is that after somebody responds to the medication, in order to stay well, they need to be on the medication for a minimum of 6 months and perhaps up to a year. If they don't continue to take it, then the depression can come back.
But there could be a point at which they can come off slowly. And
For many people, yes.
And what about the bad press of we hear about Prozac? What are the things that are supposed to be bad about it, and what about them?
Well, there are stories that you might hear that it can make people kind of wild. There was a story that's long been discredited that it can make people suicidal, that it actually makes people worse and makes them do things that they wouldn't ordinarily do. That actually gets into the whole area of manic depressive disorder or bipolar disorder, because in fact if people are depressed, but they also can become manic, which we can talk about later, sometimes if they just take an antidepressant, it can make them worse. So that's why it's so important to have the right diagnosis. But in fact, it's been one of the most studied medications in all of medicine, and is actually reasonably safe.
So then what you're saying is that if people do have bad, so to speak, reaction to Prozac, they may well have had a bipolar disorder and not just major depression.
And that's what happens a lot to people who have bipolar disorder, because just think, what happens if they have bipolar disorder but they were never manic? So they many times up to 40% of people who have manic depressive illness will present with just depression. So that's why it's so important to try to get not only a good diagnosis, but to follow people very carefully. Because those people, actually, the antidepressants can make them worse.
Okay. And who are the manufacturers of these drugs, by and large? Are they local, the corporations domestic to the United States, or?
Yeah, really the biggest corporations, the biggest pharmaceutical companies that are making it are in the United States. And it varies from Eli Lilly to Wyeth to Pfizer to GlaxoSmithKline. Those are the makers of it.
Yeah, and I have to ask you for disclosure purposes, do they fund studies done at Mass General? They fund studies that we do. Many of us will try to consult to them so they do a good job. And we take great pride in not only saying what works, but what doesn't work. And particularly at Mass General Hospital, we have very careful rules about allowing us to say anything that we want to say for studies that we do that are sponsored by these companies. And we have no problems with saying things that are not favorable if it's true. Do the companies give perks to people? They tend to, these days, they give things like pens and other small things. But they're changing the rules so that the perks are really not worth much at all. I heard something in the news about that lately. Yeah, they just changed the rules, and I think that's good. Okay. And recently we had, just a few days ago, a study, it was said to be a study, that said placebos worked almost just about, in terms of statistical significance, effectively as well as the actual medication. What do you say about that? Yeah, it's really quite interesting because the
the medications, by and large, work quite well, but the studies to prove it are very difficult to do. And there are some technical things about how to do the studies so that the placebo rate, the sugar pill, the people who feel better with just a sugar pill, is not so high. If you do the studies wrong, so many people respond to the sugar pill that it really looks like it works when it doesn't quite. So one of my colleagues, for example, in California, did a study where he looked at the people who responded to placebo and compared them to the people who responded to an antidepressant. And even though they both looked the same in terms of symptoms, it was only the people who responded to the antidepressant who functioned better. So it turns out it's not just these symptoms that we talked about, it's also functioning that's very important.
Well, how do you decide if the symptoms are still there? By asking, by observing? How do you decide?
By both.
By both?
Yeah.
So you make a sort of, it's a qualitative record, if you
right.
will. We could call it subjective, but I'm not unfavorable to subjectivity, so to speak. I don't mean it in that way.
No, that's not bad.
As a phenomenologist, I really believe all of psychology is a qualitative science and not a quantitative one, frankly. That's how I think about that.
Yeah. One other thing about placebo is that even though it can work in the short term, what's pretty clear is that the people who respond to placebo tend not to hold it over time. And that the people who respond to antidepressants and who stay on it actually tend to keep the improvement over time.
And how do you feel personally at the success rate or whatever of persons who want to kick things on their own, want to work it through therapy? And
that's many times what we see are people who have years of therapy that don't necessarily help, then they get treated with an antidepressant and they finally feel better.
But how about the opposite of people who come to you maybe freshly with depression and say they'd like to work it through? Is there any good success with that? Or?
Well, particularly with things like cognitive behavioral therapy, it's really been proven that it works very well.
And because there could be a certain kind of recalcitrant depression, too. It used to be called endogenous depression, too, right? People can kick around sometimes. There is kind of a different, well, it's a little too late because we are running out of time, but there is kind of a different essence, if you will, of a kind of characterological depression, if you will.
It's very hard to know.
It used to be talked about that.
Yeah,
no longer is.
Some people have chronic depression.
Exactly.
I mean, these are the people who only dress in black, are always pessimistic, really have a tremendously difficult time experiencing pleasure, but it can last for years.
Do you mean people who dress in black who are young, like the fashion?
No, not necessarily. No, these people are very unhappy.
The statement that the world is black,
right,
that this is a bleak place. Yes. Well, I think, unfortunately, we have to stop here, and we nowhere near covered everything on depression, let alone bipolar disorder, but that's how time goes when you're having fun, even though you're talking about depression, which is not a fun thing at all. So I hope that listeners got some good idea of what this whole notion of clinical depression is about. And at the end of the show, you will see telephone numbers to call to participate in studies, if you would so choose, at Mass General that deal with either major depression or bipolar disorder, which we did not get to discuss. And I want to thank you very much, Dr. Nierenberg, for being here, and maybe you could come back and tell us about bipolar disorder.
Well, thank you very much for having me here.
You're welcome.
It's a pleasure.
You're welcome. Good night.